Hello and welcome everyone to our latest event in the Precision Medicine and Solid Tumors event space. We're glad you joined us for this talk. Today, our speaker is Dr. Xin Jing from the University of Michigan, who will be discussing cytologic assessment of thyroid nodules in the era of precision medicine, updates in 2023 Bethesda reporting system and diagnostic challenges and pitfalls. Here's a look at today's agenda. My name is Ian Moore, and I am a Lab Relations Manager with Diaceutics. I'll provide a short background about Diaceutics as a whole, as well as DXRX, our precision medicine platform for labs. I'll then turn it over to Dr. Jing for her presentation. At the end of the presentation, we'll dedicate some time for Q&A, where we will answer your questions. Please note, you can ask questions at any time during the talk by typing them in the box below this presentation. Diaceutics is an end-to-end services provider and data analytics company specialized in precision medicine. Our mission is better testing, better treatment, and we're building towards a future where the testing ecosystem allows all patients to receive the right treatments at the right time. We believe that labs need to be involved earlier in the precision medicine decision-making process. We have experience in 96 disease pathways and have worked on every precision medicine brought to market with 36 of the top 40 pharma clients. And we have a global presence enabling knowledge sharing across a vast range of topics. All diagnostic labs can find a benefit from a DXRX registration, regardless of shape or size, and we see this collaboration having a positive patient impact all over the globe. Our goal is to break down global barriers between labs, and we see DXRX as the way to accomplish this. A free DXRX lab membership enables you to be the first to hear about exciting sponsored scientific studies and DXRX collaborations. It allows you to be part of our data-driven recommendations to increase your visibility to precision medicine stakeholders, and it provides access to lab talk and lab webinar recordings, precision medicine reports, biomarker reports, and DXRX live newsletters. On both the left side of the screen and in the DXRX booth in the exhibit hall, you'll find a link where you can schedule a meeting with a lab relations manager to learn more about DXRX and joining our lab network. We'd love to meet with you. It is now my pleasure to introduce Dr. Xin Jing. Dr. Jing serves as a clinical professor of pathology at the University of Michigan, Michigan Medicine. Her clinical interests involve diagnostic cytopathology, and her research focuses mainly on thyroid cytopathology. Dr. Jing received her medical degree from West China University of Medical Sciences in Chengdu, China. She completed her residency training in Anatomic and Clinical Pathology in the Department of Pathology and Laboratory Medicine at Tulane University School of Medicine, followed by fellowship training in cytopathology in the Department of Pathology at the University of Michigan. Dr. Jing is board certified in Anatomic and Clinical Pathology and Cytopathology. She was director of Cytopathology Fellowship Program at University of Michigan from 2013 to 2020. Throughout the years, she has been an active member of education-related committees of Papanicolaou Society of Cytopathology, American Society of Cytopathology, and Chinese American Pathologists Association. Dr. Jing serves as an ad hoc reviewer of several professional journals, including Cancer Cytopathology, Diagnostic Cytopathology, and Endocrine Practice. She is a current editorial board member of Diagnostic Cytopathology. And with that, Dr. Jing, I will turn it over to you. Thank you for joining us.
Good afternoon, everybody. Thanks for the nice introduction. So the title of my talk is Clinical Assessment of Thyroid Nodule in the Era of Precision Medicine, Updates in 2023 Bethesda Reporting System and Diagnostic Challenges and Pitfalls. There are 4 learning objectives outlined here. And first, review updates in the 2023 Bethesda system for reporting thyroid cytopathology. Second, recognize cytomorphology patterns of thyroid fine needle aspiration. Third, identify pitfalls and challenges in thyroid fine needle aspiration cytopathology. Last, I will spend a little bit time discussing the role of ancillary tests as adjuncts to cytologic assessment of thyroid nodules. It's a multidisciplinary approach to thyroid nodule management and treatment. Clinical teams make plans based upon the findings in patients' physical exams, past medical history, and family histories, and laboratory testing results, as well as ultrasound findings, finding the aspiration cytopathology results, and molecular profile. So I'm a cytopathologist. So today I'm going to spend most of the time talking about cytomorphology of finding the aspiration of thyroid nodule. And at the end, I will spend a little bit of time talking about molecular testing, the role of molecular testing for risk stratification for the intermediate thyroid nodule. So it has been well accepted that FNA is a very important tool in the evaluation of thyroid nodule in terms of differentiating benign non-neoplastic nodule from neoplastic or malignant nodule. It has a very good diagnostic accuracy in terms of diagnosing papillary carcinoma, which is a most common thyroid primary malignancy. It is very critical to communicate thyroid fine needle aspiration interpretation to referring treating clinician. So using a standardized, uniformed reporting system is a very important way to avoid miscommunication or to minimize confusion. So the Bethesda system for reporting thyroid cytopathology has been widely accepted as a uniform reporting system. It was first published in 2010, and later on, the second edition was published in 2017, and the third edition was published just last summer. So each later edition was published just reflect some developments and changes, since the early edition. For example, the second edition published after the endorsement of the first edition by the American Thyroid Association, and also the implementation of molecular testing for the intermediate category thyroid nodule, and also implementation of histologic diagnosis of NFP. This NFTP used to be categorized as a malignant lesion. In 2016, it was excluded from the malignant category. So the second edition of the Bethesda reporting system also excluded NFTP from the malignant category. And the third edition of Bethesda system, try to reflect the changes, made in the 2023 WHO classification of thyroid neoplasm. So there are some changes made in the most recent edition, which is 2023 Bethesda system. Unlike the previous two editions of Bethesda reporting system, the 2023 Bethesda reporting system used the single term for all 6 diagnostic categories, including non-diagnostic, benign, atypia of undetermined significance, follicular neoplasm, suspicious for malignancy, and malignant. For atypia of undetermined significance, we need to specify if the atypia is nuclear atypia or other type of atypia. For follicular neoplasm category, we need to specify if it is oncocytic type follicular neoplasm or not. And also for the indeterminate categories, meaning atypia of undetermined significance of follicular neoplasm suspicious for malignancy, molecular testing is recommended. It is useful for further risk stratification. And also in the 2023 Bethesda system, the risk of malignancy for each category is updated. Also, the management guideline is revised or updated. In this regard, repeat FNA with ultrasound guidance is recommended for non-diagnostic category, and clinical or ultrasound follow-up is recommended for benign nodule. And repeat FNA, molecular testing, or diagnostic lobectomy or just surveillance is recommended for atypia of undetermined significance. Molecular testing, diagnostic lobectomy, for follicular neoplasm, molecular testing, lobectomy, or near total thyroidectomy for suspicious for malignancy, lobectomy, or near total for malignant. The other thing we need to, okay. I need to click it. Oh, okay. The other thing we need to pay attention is that we mentioned NAPP is not considered a malignancy anymore. So you notice that if we exclude NAPP from malignant category, the risk of malignancy would be decreased for each of the diagnostic category. But the most affected category would be those 3 intermediate category, right? You see those circled in the green circle, like AUS category, follicular neoplasm category, and suspicious for malignancy category. I mean, they show significant decrease in risk of malignancy after excluding NAPP from the malignancy. The other changes in the 2023 Bethesda system, including some changes in revised nomenclature. For example, using follicular nodule disease under benign category. Before we use choroid nodule, adenomatoid nodule, nodular hyperplasia. So now we just use follicular nodule disease. Follicular neoplasm, oncocytic follicular neoplasm is preferred before we use Hurtle cell neoplasm. Papillomathiroid carcinoma subtypes replace papillomathiroid carcinoma variants. High-grade follicular-derived thyroid carcinoma is used, which covers poorly differentiated thyroid carcinoma and differentiated high-grade thyroid carcinoma. And also, there are two brand new dedicated chapters in the 2023 Bethesda system. And one just talk about importance of clinical perspective and imaging findings. The other one talk about molecular testing in thyroid disease. And also this new Bethesda system has been endorsed by the European Federation of Cytology Societies. And the new Bethesda system also has expanded discussion on the reporting and the management of pediatric thyroid disease. The risk of malignancy has been calculated for each category and linked with commonly practiced guideline. You probably notice that for those undetermined category, again, AUS category, follicular neoplasm category, and suspicious for malignancy category, the risk of malignancy is way high compared to adult population. Here, 28%, 50%, and 81% for each of the categories I just mentioned, respectively. Among all those three undetermined categories, the AUS category likely is the most heterogeneous and challenged category. This is a category reserved for specimens that contain cells with architectural and/or nuclear atypia. The specimen contains those atypia which is insufficient to be categorized as follicular neoplasm or suspicious for malignancy or malignant. However, the atypia is so obvious that cannot be categorized confidently as a benign nodule. However, we should not use this AUS category as a waste basket. So Bethesda system actually recommends limited use of this category in no more than 10% of your total thyroid FNA specimens. So somebody recommends use AUS to malignant ratio using the ratio 1.0 to 3.0 as a quality measure to detect over-diagnosis of AUS or under-diagnosis of malignant. If the AUS to malignant ratio is more than 3%, you may overdiagnosis of AUS or underdiagnosis of malignant. So there are some useful approaches to establish a reasonable diagnostic threshold, which is useful to limit your diagnosis of AUS. One is using peer review or group consensus review approach. The other one just use a real-time cytohistologic correlation. The other approach is to know the basic cytomorphologic pattern. In other words, know the pattern recognition. I mean, in the Bethesda, we all can read the text, but recognizing the pattern is somehow is different. So let me show you what I mean in the next few next few slides. So over here, I just show you an example what we mean the monolayer honeycomb arrangement. This kind of arrangement usually show in a benign follicular nodular disease. On the left panel is this is a diff quick stain, and on the right panel this is a Papanicolaou stain. So when we talk about a monolayer honeycomb arrangement, you can see the cells are arranged. I mean, the the nuclei respect to each other, right? The nuclei are evenly dispersed and no nuclear overlapping, and no nuclear clouding. You look at each nucleus, they look bland, and they are either round or oval and with smooth nuclear membrane and fine chromatin, inconspicuous nucleoli. And over here is another example of monolayer honeycomb arrangement. So when you take low power, you may feel, oh, it looks a little bit scary. However, if you look on the high power view, it still gives you that monolayer honeycomb arrangement. You see nuclei are evenly distributed and no nuclear overlapping, and the nuclei respect to each other, no nuclear clouding. So although they look large, but they still have that monolayer honeycomb arrangement. And over here, it's a diff quick staining smear. And you notice that they are a group of cells. You look at the edge, the outline is very smooth. This is the type of arrangement we call it intact follicles. So we got many intact follicles. You look at high power view, it shows you a better view on how the outline, how smooth the outline is. Again, this is a Papanicolaou stain smear, show you many intact follicles. You see a lot of bland looking cells, but you look at the outline, they are very smooth looking. The cells, the nuclei look bland. These are intact follicles. We usually see those kind of follicles in benign follicular nodular disease. And here, a higher power view of intact follicles, spherules. So again, we often see this kind of intact follicles in benign follicular nodular disease. Okay, look at this slide. This kind of cellular arrangement is different from the monolayer honeycomb arrangement we just showed. How different? Because you look at the cells over here, the nuclei respect to each other and know they are evenly distributed. However, you look at this sheet, the nuclei are not evenly distributed. You look at here in the left center part, some areas that they are more clouded. If you look at the right lateral part, medial part, the nuclei are more spread out. So nuclei are not evenly distributed. You look at the more clouded part, it's hard to tell one cell border from the other. So we call this kind of arrangement like syncytial arrangement. So totally different type of arrangement, honeycomb arrangement and syncytial arrangement. Honeycomb arrangement may be seen in benign follicular nodule disease. On the other hand, syncytial arrangement arrangement is seen in classic papilloid carcinoma. Okay, here just to show you how microfollicles in a Diff-Quick stain smear. Unlike intact follicle, you can see microfollicles, they don't have smooth outline. You look at the edge, it's not smooth. You see nuclear overlapping here. So this is microfollicle, not intact follicle. Just for comparison, left panel microfollicle with irregular outline and nuclear overlapping, and right panel with relatively smooth outline. Both are Diff-Quick stain. And another example of microfollicle in a Papanicolaou stain, again, irregular outline with nuclear overlapping. And this is an example just showing you, this is an oncocytic lesion. You see a lot of oncocytic cells with printed cytoplasma here. We actually can appreciate nuclei with prominent nucleoli. But if you look at the center part, there are some spindle-looking nuclei. They are actually the endothelial lining of a transgressing vessel. We may see this kind of finding in oncocytic follicular neoplasm. So this is a very helpful feature actually in the when we want to diagnose oncocytic follicular neoplasm. So some pitfalls. One I would like to share with you is that the presence of minor portion of small size follicles like these over here in the setting of predominantly monolayer honeycomb sheets. I refer to these is consistent with follicular nodular disease. So in case like this, we don't upgrade the this kind of finding to AUS. We allow minor portion of the microfollicle in setting like this as follicular nodular disease. The other thing is neither intranuclear grooves no pseudo inclusions are specific for papilloid carcinoma. Like this one, we saw a lot of inclusion, but this is actually the case of follicular nodule disease, not papilloid carcinoma. So be careful. Don't overcall PTC because you see intranuclear inclusion. As a matter of fact, intranuclear inclusions may be seen in both malignancy and benign. For example, it can be seen in papilloid carcinoma, oncocytic cell neoplasm, major thyroid carcinoma, anaplastic thyroid carcinoma, metastatic malignancies such as melanoma, And we just show you an example. It can be seen in benign follicular cells, and sometimes cystic lining cells may contain intranuclear inclusion. And also intranuclear grooves may be seen in papillary carcinoma, follicular neoplasm, medullary thyroid carcinoma, follicular nodule disease, and also another benign entity, Hashimoto thyroiditis. All right, let's go through some cases. Case 1. This is a 33-year-old lady presented with a 2.5 centimeter right thyroid nodule. Ultrasound-guided FNA was performed, and conventional smears were provided for second opinion. This was an outside case. So let's see. Those two images were taken from deep quick stain smear. So basically, all we saw here were just histiocytes. And this imaging were taken from Papanicolaou stain. So basically, we saw cell groups, bland looking, and with smooth outline, similar to what we saw before, right? I just show you some something look like spherules, intact follicles. Now, let's see, what is your diagnosis? The choices are benign follicular nodule disease, AUS, follicular neoplasm, follicular type of PTC. Let's see. All right. I got 40% choose benign follicular nodule disease, and 40% choose follicular type of papillary carcinoma, and 20% choose AUS. All right. So I would say I would agree with benign follicular nodule disease, because basically what we saw are just intact follicles. We don't see anything look like microfollicle, and also we don't see good features of PTC. Again, for follicular type of papillary carcinoma, we also need to see microfollicular arrangement, which we don't see in this case. So actually, the preliminary diagnosis made at the referring institution was suspicious for follicular neoplasm, but we revised it as a benign follicular nodule disease. The next case, a 44-year-old lady presented with multiple thyroid nodule, one in right 2.0 centimeter and two in left 1.3 and 1.9 centimeter, respectively. Ultrasound-guided FNA of right thyroid nodule was performed. Conventional smears were provided for review. Okay, both images were taken from deep quick stain smear. You can appreciate that they are hard colloid and water colloid in the background, and In between, you can see monolayer honeycomb sheets. Under higher power, you can appreciate that they are more look like oncocytic cells, right? They have more cytoplasm. But again, it's like monolayer honeycomb arrangement with evenly distributed nuclei, no nuclear overlapping. So what is your diagnosis? The choices are follicular nodule disease with oncocytic hyperplasia, consistent with Hashimoto, lymphocytic thyroiditis, AUS, and oncocytic follicular neoplasm. Okay, I saw most of you choose follicular nodule disease with oncocytic hyperplasia. That I agree, because we saw a lot of colloid in the background, and second, we saw monolayer honeycomb arrangement of oncocytic cells. We don't see architecture or nuclear atypia. So the overall findings are consistent with follicular nodular disease. Why this is not oncocytic follicular neoplasm? And later on, I will show you a case of oncocytic follicular neoplasm, and then you can tell the difference. Okay, move on to case 3. A 41-year-old lady presented with a 4.0 centimeter right thyroid nodule. Ultrasound-guided FNA was performed, and conventional smear was provided for second opinion. This was the outside case. Okay, this is a deep quick stain smear. It's a very hypercellular aspirate with looks like almost exclusively oncocytic cells, but you can tell they are not monolayer honeycomb arrangement. Instead, they are arranged as either irregular clusters or trabeculae, definitely not as monolayer honeycomb sheets that we saw in the previous case. And also some big tissue fragments with nuclear overlapping. And on the right panel, this is a Papanicolaou stain with large tissue fragments. And in the middle, hopefully you can appreciate there may be transgressing vessel, like spindly looking, likely the endothelial lining. So again, multiple choices questions, and first AUS, second oncocytic follicular neoplasm, third follicular nodule disease with oncocytic hyperplasia, and third lymphocytic or Hashimoto thyroiditis. All right, so I saw most of you choose oncocytic follicular neoplasm. I agree with that. So now you see the difference between this case and the previous case. So this case, we see almost no colloid. This is the thing. And the second thing is that we saw architectural atypia, right? We don't see monolayer honeycomb arrangement of the cells. Instead, we saw the cells are arranged as irregular clusters or trabeculae. The third, I mentioned that when we saw big tissue fragment with transgressing vessel, this is a very helpful features, in the oncocytic follicular neoplasm. So likely this is oncocytic follicular neoplasm. And lymphocytic Hashimoto thyroiditis is out of questions because we don't see lymphocytes in the background. So preliminary diagnosis was AUS with Hurtle cell predominance, and then our final diagnosis was oncocytic follicular neoplasm. So some learning points for follicular neoplasm, including oncocytic follicular neoplasm. So when we try to make a diagnosis of follicular neoplasm, we need to see hypercellularity with or without cytologic atypia. We should not see colloid material or just a little bit colloid. And the third thing is we should appreciate some architectural atypia, either microfollicle or trabeculae or large tissue fragments with transgressing vessel. The third, mostly seen in oncocytic type follicular neoplasm. All right, let's move on to case number 4. This is a 75-year-old gentleman presented with a 1.5 centimeter right thyroid nodule. And he had a history of Merkel cell carcinoma of left leg. An ultrasound-guided fine needle aspiration was performed, and conventional smears along with a cell block was provided for review. So a deep quick stain smear show just, very cellular aspiration with those disc cohesive cells. And you can see these cells, they have high NC ratio because they have very scant cytoplasm. It's disc cohesive. So during further workup, which of the following immunostain panel is most helpful? All right, so I saw most of you choose the first panel. Let's take a look. So for this case, our major differential diagnosis should include first metastatic Merkel cell carcinoma because of his previous history. A second, major thyroid carcinoma should be included. And the third, high-grade follicular-derived thyroid carcinoma also should be included, right? And then for metastatic Merkel cell carcinoma, we all know CK20 is positive, and neuroendocrine markers should be positive. And for major thyroid carcinoma, calcitonin CA neuroendocrine marker should be positive, and occasionally TTF1 and PAX8 may show weak positivity. And for high-grade follicular-derived thyroid carcinoma, it will show positivity for TTF1, PAX8, and thyroglobulin. So to consider all three entities in the differential, the first panel should be done for completeness. So it turns out it is a metastatic Merkel cell carcinoma. Next case, a 59-year-old lady presented with a 3.2 centimeter right thyroid nodule. Ultrasound-guided FNA was performed. Again, it was a conventional smear. So Diff-Quick stained, smear showed a hypercellular aspirate with like small cells with high NC ratio. So this is our current case, and compare just with the case we just saw, Merkel cell. Really, it's hard to tell the difference by morphology, right? So fortunately, we had a good cell block. So we made, we also did immunostains for this particular case, and it showed positivity for calcitonin and chromogranin, positive, but thyroglobulin was negative. So we made the diagnosis of major thyroid carcinoma. Another case, it was a 48-year-old gentleman with a 3.8 centimeter left thyroid nodule and abnormal left supraclavicular lymph node. And he had a liver lesion. Thyroid, FNA and biopsy showed cortical metastatic adenocarcinoma, strongly positive for AE1, AE3, MARK31, CK7, TTF1, negative for PAX8, CK20, PSA, HARPA1, CDX2. So ultrasound-guided FNA of thyroid and supraclavicular lymph node was performed. Conventional smears and cell block was prepared. The left panel was from left supraclavicular lymph node. The right was from left thyroid. So basically, the cells are morphologically similar, but left was so hypercellular, it's hard to see through. But the right panel, you can see these cells are pretty big, and they have plasmacytoid looking, and they have granular cytoplasma, and some cells, they have binucleation or multinucleation. And a high power view, and you can see granular cytoplasma and binucleation, multinucleation, very large, like macronucleoli. So we had a good cell block, and then we did immunostains, cytokeratin cocktail positive, calcitonin positive, CA positive, synaptophysin positive, and the immunoprofile along with molecular findings, morphology findings are consistent with medullary thyroid carcinoma. And later on, the patient's serum calcitonin was tested as way high, so confirming it's a medullary thyroid carcinoma. And patient got surgery, and it is a medullary thyroid carcinoma involving left thyroid lobe and metastatic medullary thyroid carcinoma involving 13 out of 31 cervical lymph nodes with extranodal extension. And looking back, his liver FNA and biopsy, you look at the morphology, it's still hard to tell what it is, right? You see single cells, you see some cells, and try to form the glandular architecture. Even you look at the biopsy, some try to form glands. So later on, the calcitonin stain was added, which shows strong positive staining pattern. So the diagnosis was later on revised as metastatic medullary thyroid carcinoma. Another case, 84-year-old lady presented with a 2.9 centimeter right thyroid nodule. She has a history of lung adenocarcinoma, status post lobectomy, and treatment with EGFR TKI. Ultrasound-guided FNA of thyroid nodule was performed, and conventional smears and cell block were prepared. Varicellular aspirate. And looking at the high power, I guess most of you can tell it looks like small cell, right? The deep quick stain, you see molding, smearing, and the Papanicolaou stain on the right panel, you can see salt and pepper type chromatin, again, molding, smearing. So we prepared cell block, and then we did immunostain, which is TTF1 positive, synaptophysin positive, and CD56 positive. There are other negative staining, PAX8 negative, thyroglobulin negative, calcitonin negative, and P63 negative. So the most likely diagnosis is pre-differentiated thyroid carcinoma, differentiated high-grade thyroid carcinoma, medullary thyroid carcinoma, metastatic small cell carcinoma. So we all got it right. It's metastatic small cell carcinoma. So knowing that lung adenocarcinoma can transform into small cell lung carcinoma when resistance to TKIs occur. So some learning points I would like to make. So we we should check history when we review the cases. And also, we should think of some uncommon entities and or mimics. We should also get an optimal cell block for potential workup. And when we do immunostain, we should do a targeted panel instead of just randomly do some immunostain. Okay, the last case is a bonus. It's a 50-year-old female presented with a 2.6 centimeter left thyroid nodule. Ultrasound guided FNA was performed. Again, conventional smears were provided for review. And diff quick stain show a lot of cells and lots of normal honeycomb arrangement, but again, it's show architecture atypia, but we really don't see typical sensational kind of arrangement. Some cells look like maybe hertoloid change, but again, we don't see typical sensational arrangement. And over here, and some cells appear to have inclusions. And right panel is from a Papanicolaou stain. Some have grooves. So what is your diagnosis? Papillary carcinoma, suspicious for papillary carcinoma, atypia of undetermined significance, benign follicular nodule disease. This is, I have to say, this is a challenge case. So let's see. All right. So I saw the answer of suspicious for papillary carcinoma. I understand why why people pick up this option, because I was one of them, initially making this call. However, let me show you what the surgical follow-up show. So this is a histology. Actually, this was, I think this is the right panel show a high power view. I think this high power view is from the, if you look at the, I'm not sure if you can see my arrow. If you look at the left upper part, it's more solid part, and these areas show reparative, reactive change. So basically, these changes are not malignant change. They are reactive reparative change in benign follicular nodule. So looking back, I think it's more reasonable to call it AUS instead of suspicious for PTC. And also, I look back, the only thing I noticed that although they show architecture atypia, I really don't see a good sensation type arrangement. They more look like a heteroid change. So this is a learning lesson. So it's a good case. I think we learn from our mistake. All right. So we still have okay. I'm going to spend maybe 5 to 10 minutes just talk about molecular testing, as an adjunct to further stratify the intermediate lesion, mainly for the AUS and the follicular neoplasm category. So the role of molecular testing for thyroid FOA includes further stratification of molecular risk in indeterminate nodule, stratification of prognosis in terms of surgical options for these nodules, and also identification of systemic therapy and clinical trials tailored to a particular tumor's molecular profiling. Currently, there are 3 commercially available molecular tests in the States, Thyroid, Affirmer, and Thyroid. So analyze biomarkers, methods, technology, and accepted study material for each test has been summarized in the new Bethesda reporting system. And then this table I copied from the new Bethesda. So basically it shows the data from their clinical validation studies. And currently, according to the new Bethesda, there's only one single institution study showing no significant difference in the diagnostic performance of Thyroid and Affirmer GSC in thyroid nodule categorized as AUS or follicular neoplasm. And in our institution, we did 2 studies in Affirmer GSC testing. And the first study, we tried to see the performance of GSC in subcategorized nodule in ASC category. So basically, we found that the benign call rate of GSC is higher in architecture atypia. The malignant rate in GSC suspicious lesion is higher in AUS with both architecture and cytologic atypia. So we conclude that benign call rate of Affirmer GSC and malignant rate associated with suspicious GSC may differ in various AUS subcategory. And again, AUS architecture atypia shows significant greater benign call rate than AUS with both architecture and cytologic atypia, and AUS with both architecture and cytologic atypia demonstrated significantly higher malignant rate compared to AUS with architecture alone. So these findings might guide more appropriate clinical triage and improve management of patients with AUS thyroid nodule. The other study we did, we tried to compare the GSC performance in patients with single AUS diagnosis versus patients with repeat AUS diagnosis. So basically, we found no difference between the two patient cohorts. So again, we conclude that GSC demonstrated comparable performance in thyroid nodule with a repeat AOS diagnosis versus nodules with initial AOS diagnosis. So with that, I conclude my talk. Thank you for your attention.
Yeah, thank you, Dr. Jean, for that really fun, interactive, and great presentation on the thyroid pathology. We really appreciate it. In the interest of time, we'll conclude with one question here. So the question is, in your institution, how are thyroid FNA specimens triaged?
All right, so in our institution, the thyroid FNAs are performed mainly by the endocrinologist or endocrine surgeon. Occasionally, they are done by our ENT doctors. So most of the FNAs are done with cytologic assistance roles. So most of them are done with conventional smears prepared, and then when those are performed, our cytotech prepares smear, and using the tele, and cytologists will do the adequacy check, and through the telecytology at that time, and we would try at the sample. Depending on what we see, we may tell to do the cell block or thin prep, or sometimes depending on what we see. For example, if we suspect lymphoid proliferative disorder, we may also ask for additional paths sending for flow cytometry.
Awesome. Thank you for that. And thank you for taking the time to speak with us. And a big thank you to everyone in the audience as well. We'd love to speak with you about DXRX. So if you're interested, please check out the link to book a meeting. And we encourage everyone to stay connected with Diaceutics for future events. So thank you again to Dr. Jing, and we hope everyone enjoys the rest of their day.
Thank you.